Afternoon, all of you. It's 1:30, so I think it's time to start our session. Thank you very much for coming here, and we will have an interesting session this afternoon in the coming 90 minutes. The title of the session is Challenges in TB Diagnostics, an overview of methods and issues, and that is indeed what we will address. We can more or less divide our session in 3 or 4 parts. And the first part is looking at data. We have data from the laboratory. Over the last few days, you have heard maybe in many sessions, we don't have data, we need data, we are lacking data. But actually, we do have data. We do have lots of data, but they are often hidden in the books. And we do not know what kind of treasure there is hidden in the books. So our first presentation will look at what we can do with the data from registers, and then also addressing a new a significant problem of bovine tuberculosis. The other 5 presentations will look at different aspects of methods for diagnosing TB. And the concept is no method fits all. The expression is, I think, one size doesn't fit all. And we will see that. And we will see old methods putting into new ways to revive the microscopy. We will look at how we can increase the sensitivity using serial testing, using molecular testing, etc., to increase the sensitivity of diagnostic testing. Then, when we have the appropriate method in the laboratory and we can select the one fitting our local circumstances, that is not the end of the game, because we are, as you have heard also, dealing with the cascade of patients. Patients need to be, first of all, be identified as presumptive patients, and then only they can go into the diagnostic pathway. And we will see examples of that from Bangladesh. And once they are in a diagnostic pathway and all the methods are in place and we have a good policy of it, then we will see that that policy is not really implemented properly. And we have a good example of that from the Khayelitsha workshops, Khayelitsha data. Cost will be addressed in one of the sessions, and then our last session will look actually at our last measurement of importance, which is the impact of all our diagnostic services on the outcome of the patient care. So that's in a nutshell what you can expect during this session. We have 9 sessions. It's not a short oral, but still it is very short. We only have 10 minutes for each presentation. And if we would allow time for 1 or 2 questions after each presentation, then we need to have 8 minutes for each presentation. I forgot to introduce ourselves before introducing the speakers to you. Next to me is Alain. She is working for MSH in South Africa. Okay, you can read our names here. And I'm working in Amsterdam at the Royal Tropical Institute. So thank you, and please let us enjoy this session. Lean back in your comfortable chairs. And then I would like to invite the first speaker. And he's going to give the talk, Serial Molecular Testing Improves the Detection of Tuberculosis in a Low Prevalence Setting. Thank you.
Thank you. Good afternoon. As evidenced by this session and a number of presentations at the conference, there are a number of new TB diagnostics that are currently at various stages of development, evaluation, and/or implementation. However, published reports of test performance can range widely, particularly when they are assessed in different populations or in different countries. Therefore, it's important to validate new diagnostics in the setting in which they will be utilized. And this underscores the importance and the need for us to understand the determinants of variable test performance among different populations. And this is true, I think, for tests we'll hear about today, like Xpert MTB-RIF and TB-LAMP, as well as a number of other diagnostics that are currently underway. Los Angeles County, where this study was performed, has a population of about 10 million and a TB case rate of about 6 per 100,000. In 2013, the Department of Public Health developed a polymerase chain reaction or PCR-based test for TB diagnosis, and our objective was to assess the performance of this test under routine program conditions. We had several specific questions that we were trying to answer. First, how much does PCR improve the rapid diagnosis of patients with smear-negative or possibacillary disease? Second, what is the value of PCR for identifying patients with smear-positive sputum specimens that will not grow TB, represented by patients who do have specimens that grow non-tuberculous mycobacteria or NTM? And third, how much does serial PCR testing, meaning collecting and testing more than one specimen per patient, increase the diagnostic yield for patients with smear-negative TB? The study period began in early 2014 and extended into the middle of 2016 for a period of about 30 months. Patients were enrolled from public health clinics, which includes a wide variety of patients, those who were referred for symptoms worrisome for infectious TB, but also recent contacts who may be evaluated for things such as an abnormal X-ray with or without symptoms, and immigrants from overseas who had abnormal chest X-rays through screening overseas, who again may be with or without symptoms. All individuals were evaluated for pulmonary tuberculosis with serial sputum smears over several days, and all three of the specimens for each patient were examined by AFB smear microscopy, PCR, and mycobacterial culture. We use a real-time PCR assay that targets the IS6110 insertion element of Mycobacterium tuberculosis complex with an internal amplification control to assess for inhibition. Specimens with results just below the positivity cutoff were retested. And one important point is that specimens were tested as part of a batch process each day. And this is important because the marginal cost of doing additional tests was actually quite minimal once the platform was set up. This figure shows the tests performed over the study period. As I mentioned, from early 2014 to the middle of 2016, we tested almost 11,000 specimens. And that was about 250 to 400 specimens tested per month with the PCR assay. Overall culture results, about 3/4 of specimens showed no growth. A little bit less than 15% grew non-tuberculous mycobacteria, and about 8.5% grew Mycobacterium tuberculosis complex. This figure compares the sensitivity of smear microscopy to PCR. As fitting with numbers presented from other data in the United States, smear microscopy had a sensitivity of approximately 61%, while PCR had an improved sensitivity of about 80%. We also stratified those results by smear status. So the PCR sensitivity varies according to the bacillary burden. Among specimens that were smear negative, the sensitivity was about 50%. In contrast, among specimens that were sputum smear positive, the sensitivity was much higher, approaching 100% at 98.3%. One thing that's important to recognize is that these two categories are not homogeneous. And as we look at them a little more closely, we can understand that there are different trends even among these sort of large categorizations. So looking at smear positive specimens, we further separated them into smear grade. As you can see, most of the decrease in sensitivity among smear-positive specimens is around those with lower grade, 1+ primarily and a little 2+. But any specimen that was 3 or 4+ was positive by PCR. The same sort of trend is seen in smear-negative specimens. These we stratified by days to culture positivity. And as you can see, in the specimens that were more possibacillary, had less of a disease burden, the sensitivity of the test was less. And as disease burden increased, the sensitivity of the test increased as well. While this might be intuitive, this is very important to understand why the test might perform differently in different populations. We also looked at the specificity of the test. Overall, the specificity is quite high, approaching 99%. And then we looked specifically at specimens that grew non-tuberculous mycobacteria and found that the specificity remained high at 98.4%. Now, this is of particular importance in our setting, where 39% of smear-positive specimens grow NTM and not MTB. We also looked at the yield of serial PCR testing. So this is among patients with smear-positive, culture-confirmed tuberculosis. And the first specimen, while high, you'll notice that the scale here is quite different. This is ranging from 80 to 100%. The first specimen already has a sensitivity of almost 87%, but there is some additional yield of the second PCR in patients with smear-positive TB. But this really is a reflection of specimen-to-specimen variability. Because when we looked, we found that 22% of our patients with smear-positive specimens, defines at least one of their three was smear-positive, culture-positive. The reality was that 22% of them, the first specimen was smear-negative. And so this is something that I think we all know from dealing with smear microscopy in general, but we see the same trend is true when dealing with PCR testing. The real increase in serial yield was among patients with smear-negative disease. Here we see a sensitivity of this range is from 30 to 50%, 55%, far different from the previous slide. But we see a great increase with each sequential PCR test performed in smear-negative disease. So this is a reflection that the value of additional tests changes according to the bacillary burden. So these are the three questions that we asked. The first question was, how much does PCR improve the rapid diagnosis of patients with smear-negative TB? And we found that 50.7% were PCR positive. And so this allowed for a rapid diagnosis in less than 1 day, about half of patients with possibacillary disease who otherwise would be diagnosed weeks to months later. Second, we asked what the value was in identifying patients with smear-positive sputum specimens that will not grow TB. And as I mentioned, the specificity was quite high, approaching 99%. And this allows rapid confirmation that these patients with NTM growth do not have TB, avoiding toxicity of unnecessary TB treatment. And our final question was about serial PCR testing. So among patients with smear-negative TB, we saw a large improvement in sensitivity, 18.5% of 3 PCR tests versus 1. And this is particularly high yield for patients with possibacillary disease. Among patients with smear-positive TB, which was unexpected, there was still substantial improvement with specificity. Again, we were starting at 86% sensitivity, but there still was a substantial increase with a second PCR specimen. And this is important in our setting for infection control because decisions about airborne infection isolation in a hospital setting or even home isolation are contingent upon upon the PCR results in a patient with smear-positive specimens. A couple of limitations that I think are important to mention is one is the population examined has a relatively low prevalence of TB, about 8.5%, and a high prevalence of NTM, which makes for us the importance of using PCR testing in smear-positive specimens especially important. And second, the low marginal cost of multiple PCR tests is not representative of commercially available tests. I think later today we'll hear some cost-effectiveness analysis, but in our setting, the possibility of doing multiple tests per patient was actually quite easy. So in conclusion, routine use of PCR performed extremely well in a low prevalence setting with high sensitivity and specificity at a relatively low cost. A couple of important takeaways is one, that diagnostic test sensitivity varies based upon bacillary burden. And this should really be taken into account when assessing new TB diagnostics, whether it's for diagnostic sensitivity, whether it's meta-analyses of studies across different areas, or whether it's looking at clinical outcomes. The same can be true. We need to make sure that the populations we're comparing for different tests or even the same tests in different places are similar. Otherwise, we'll get different results. Finally, testing of serial specimens has additional diagnostic value, particularly in low prevalence or possibacillary populations. And this may have implications for parallel processes in high prevalence setting, such as active case finding among people living with HIV. Thank you.
Thank you very much for your interesting presentation. And yes, maybe let's take a few questions now, also for the previous presenters. A short session of questions, and then we continue with the next presentation. Anyone like to ask a question to one of the
microphone?
Yes.
These work?
Yeah.
Okay. Can you hear me? No? Yeah, okay. So I just came in late a little bit, and I see the serial specimen testing. What about nested PCR? Have you compared the advantages of doing a nested PCR on one sample versus the serial?
Yeah, so actually in the data I presented here, we looked at the value of one PCR using this assay versus several. And this, in addition, has been compared, not data I'm presenting here, to commercially available tests, which uses a nested PCR, and the performance is similar. This test is not assessed for rifampin resistance, which is actually a whole different question. In our setting, with a low rifampin resistant prevalence, positive test results are actually more likely to be false positives.
Yes, some more questions for the previous speakers? Yes, one moment. Yeah, oh, yes.
I have some questions for the second presentation.
Yes, please.
Concerning the smear reading, one is that you said it's low cost. Can you give us an idea of what you mean by low cost? It may be high cost for some people, what other things low cost. I would like to ask if it's an LED based or it's a gas lamp based microscope that you're using. And if I understand correctly, you have to load the slides one by one, so there is no walk-away window. And finally, your aggregate figures on sensitivity and specificity, it would be interesting to see a breakdown if there is public data available. For example, if it's a go-no-go type of test, if a human reading is 3-cross and an automatic reading is scanty, you still take it as a positive case. So it would be interesting to see a little bit the breakdown on the differences of the WHO gradings.
Okay, thank you. Can you answer those questions, please?
The last speaker, I would like to ask
Oh.
if the ruling out of
Yes.
false positive test was required because you didn't have the ability to rule it out otherwise. In other words, let me ask it another way around. Is it positive finding and to not treat somebody who doesn't have TB is very big cost saving? And did that aspect of your PCR program, was that important?
Okay, before you answer that question, let's first continue with the answering of the question. Thank you very much for your question. The answering of your question on the automatic reading of the slides.
For your first questions, you're talking about the cost of the microscopy system. So it's about one.
Please, can you use the microphone?
Hello.
You
Yeah.
can use this one.
Yeah.
The cost of the microscopy system is about half the price of the usual microscopy system that people use. So it's much cheaper than the others. And so for and how about your second question? Can you say again? Yes. Sorry.
I don't know half of what, but half of something. It can be culture, it can be PCR, it can be, what do you mean half of?
Actually, because we also try other systems like Olympus and this kind of middle range system. So, and our system is about half the cost, half the price of this such kind of system.
Okay, I was asking about LED versus gas and one-by-one feeding.
So, sorry, can you say again?
That's your fluorescent light source. Is it LED based or is it gas lamp based?
It's a LED based.
And then you have to load the slides one by one of your moving stage.
Yeah, for the current system, we have to load one by one, but we later will maybe combine with this automatic loader. Yeah.
Okay, thank you very much. Can you briefly answer the question and otherwise, yeah?
So, very briefly, as I mentioned, the number of patients with smear-positive specimens who don't have TB is quite large in our setting. And the results are, of course, unnecessary treatment with its toxic effects, but also a lot of resources and work in terms of isolation, hospital days, contact tracing. And it's been shown, actually, that use of molecular testing has reduced all those things. And that's also true in our setting. So it actually was very important.
Okay, thank you. Before taking the last question, I'd like to ask Dr. Daru already to take the stand. Then we directly continue with your presentation. Yes, your last question, please.
Thank you very much. My question is to the first presenter.
Yes.
Did you try to tease out why is it so that M-bovis is more common or prevalent in old age than the young ones?
Thank you very much. So we stratified, of course, the different characteristics. So we figured out that the German-born patients are at older age, but not necessarily foreign-born patients. So that's why we came to the conclusion that the older German-born patients might have been infected in Germany, while other patients not necessarily. I'm not sure if this answers your question.
Did that answer your question? Was the question?
There could be some biological explanation why it's more different in old age as compared to young age.
Yeah, so we think it's related to the exposure, and that for elderly people at their time, when they might have been exposed to TB primarily, and bovis was more prevalent in Germany. So that's our explanation. If there are other explanations, please come back to me after the session.
Okay, thank you all very much. We're going now to another challenging topic, the diagnosis of extrapulmonary tuberculosis. Dr. Daru, please. Dr. Daru is from the Interactive Research and Development in Dhaka, Bangladesh, and they work closely together with the NTRL in Bangladesh. So we're waiting for the new presentation to come. How is this automatic?
Yeah. Is automatic or?
Oh, he's sleeping a bit. Hello. Maybe if we all shout, he will wake up. Oh, that's
Green?
Black. No, the
No.
okay. Hello. Hi. Can you give us the next presentation, please? Yes, I think something is happening there. Come. Okay, thank you.
Good afternoon. Diagnosis of extrapulmonary is always a challenge for the TB program. Extrapulmonary lesions are usually possibly, so conventional microscopy could not detect AFB usually, and also other histological and tuberculin tests are not bacteriological evidence as well as non-sensitive and specific. As culture needs sophisticated equipment and trained manpower, maintain high biosafety level, so this cannot be utilized due to less accessibility. So there is a need for simple and low cost sensitive and low cost sensitive and specific tests for the bacteriological evidence of extrapulmonary TB. An Xpert may fulfill all these requirements. So the objective of this study is to detect Mycobacterium tuberculosis complex from extrapulmonary specimen by using Xpert MTB reef. Method study population is actually all type of patients with extrapulmonary symptoms. This might be all new or some are already treated, but any TB patients with extrapulmonary lesions. Study place, actually this intervention was taken place in NTRL, I mean National TB Reference Laboratory, Bangladesh, and which is part of the National Institute of Disease and Chest and Hospital, NIDCH, which is the biggest chest disease hospital. Actually, although this is chest disease hospital, but it is known as a big TB hospital in Bangladesh. So the patients attending in the NIDCH, I mean National Institute of Disease of Chest Disease and Hospital with extrapulmonary symptoms were referred to National TB Reference Laboratory for collection of specimen. And samples were collected from all the patients with different extrapulmonary lesions aseptically. And Xpert MTB reef assay was performed as the standard. The automatically generated results were read after 90 minutes. All the results were recorded and in a separate register. And data from July 2014 and June 2015 were collected and analyzed. So The results show we have collected almost total 295 patients sample within this 1 year, and out of them male is 138, this is 46%, and female comes 157, that is 54%. So out of them, 99 shows MTB positive and 196 is MTB negative. If we look at the age distribution, there is from 0 to 10 and more than 60, all categories are there and different, but we, among these 295 samples, we got more in from the active age group, I mean 21 to 30 age group, this is 43%, and others are low, and lowest is actually from the 0 to 10 and more than 60, this is 4 and 4. So from different types of lesions, I mean specimens, we got highest is bronchoalveolar lavage, this is 84. And from this 84, we got 21 positive, and all are actually sensitive, rifampicin sensitive, but 5 indeterminate. And lymph node is the most common in Bangladesh, but in this study group we find only a few less than bronchoalveolar lavage. So this is 59. Out of this 59, we got 28 patients, and all 26 are out of this 26, 26 are rifampicin sensitive, and 2 out of them come to reef resistance. And likely other samples also found, and another is the pleural fluid. So from pleural fluid, we 35 samples were assessed, and out of them 5 comes MTB positive, and 4 are sensitive, and 1 come reef resistance. So these samples also sent for culture, and culture was done simultaneously with the Xpert test, and result was compared. So out of this 99 positive, 83 are culture positive, and 16 come culture negative. And out of this 196 negative results, culture negative, culture positive comes culture positive 4 patients, and culture negative 192 patients. So in conclusion, diagnosis of extrapulmonary TB is a major challenge that I have told earlier, and Xpert MTB reef is likely to play an important role in providing rapid molecular diagnosis assessment of suspected extrapulmonary TB. From our result that the Xpert assay is showing can be applied for the extrapulmonary specimen with high yielding rate, which coupled with the speed and simplicity make this technique a very useful tool for the diagnosis of extrapulmonary tuberculosis. However, the further studies are required to evaluate the usefulness and cost effectiveness of the Xpert MTB reef to diagnose extrapulmonary tuberculosis. So thank you.
Thank you very much, and you are within time, so we have some time to ask for some questions, yes? Yes, you have a question, please. Yeah.
I'm Dr. Vishnu from India. Can we use GeneXpert as a exclusion test for extrapulmonary TB? Not as an inclusion.
No.
Exclusion test.
No, exclusion test is very difficult because by GeneXpert test, even we cannot exclude the pulmonary. How we can exclude extrapulmonary?
Sorry, Mahesh Shah from Protein Logic in the UK. I'm a little bit puzzled. I'm not a clinician, but I understand that there are no particular specific symptoms which will alert a clinicians to somebody having extrapulmonary TB. So you excluded other things, and then you go on a mission to exclude that they have extrapulmonary TB. Is that correct?
No.
So there are symptoms for extrapulmonary TB?
Yeah, there extrapulmonary is a very prominent symptoms, actually, swelling of the glands and joint swelling of the joints, pleural fluid, fluid in the pleural space. So this is prominent symptoms, easily a clinician can identify and refer for the.
So I understand that the biggest challenge is getting the clinical samples in the first place.
Yeah.
And that's not so rapid.
Yeah.
That often takes time.
Yeah.
So it's only once you've got the clinical sample that you can then do
Yeah,
a
sure.
diagnosis using Xpert. Thank you.
Yeah, because this Xpert test cannot be done in the periphery setting. It needs some sophisticated setting, big setting to collect the samples.
Yeah, okay. Last question.
Peter Sigelski from the US CDC. I'm curious about including bronchoalveolar lavage specimens in a category of extrapulmonary TB, because bronchoalveolar lavage, of course, is pulmonary, not extrapulmonary.
Yeah.
So can you comment on that, please?
Actually, bronchoalveolar lavage is included in extrapulmonary. It is, bacilli which might be come out from lungs, but this is included here actually because we were getting more things, but I cannot say this is, exactly all are pulmonary, all not extrapulmonary.
Okay. I mean, this is great data. A lot of people, and it's interesting work. There's a lot of interest in using Xpert for extrapulmonary disease, and so data like this I think are valuable, but I was just curious about the BAL.
Yeah.
Okay, thank you.
Thank you.
In a recent survey of 24 countries using Xpert, only 4 countries were using it for EPTB diagnosis. So indeed, there's still a great, the interest is not great, but the potential is great. Thank you very much.
Thank you.
The next speaker is Dr. Sheet. Thanks a lot. And she will answer the question, can we use LAMP as a diagnostic test, and how best to answer that question using a systematic review. So her presentation will be a systematic review of the diagnostic accuracy of TB LAMP for pulmonary tuberculosis. And Dr. Sheet is working at San Francisco at the Division of Pulmonary and Critical Care Medicine. Thank you.
Thank you, and thank you for having me. Yes, I'll be presenting results of a systematic review that we conducted over the last, last year, that went on to help inform recent guidance that you've all seen presented at this conference from WHO regarding the use of TB LAMP for pulmonary tuberculosis. I have no conflicts of interest. The objectives of this talk really are to follow kind of a standard protocol for systematic review and present some of those results. I'll give you some background and some of our methods, our search results, describe some PICO-like questions that we addressed, and provide some conclusions based on these results. So by way of background, many of you know TB LAMP, which stands for Loop-Mediated Isothermal Amplification, was developed by ICAN to be a rapid point-of-care diagnostic. It's a manual assay with results that are possible in 2 hours and with minimal infrastructure requirements. It's read with just by the naked eye using UV light. It's been evaluated in clinical settings previously for a 2012 Xpert group meeting because it only just demonstrated specificity of 95 to 96%. ICAN went on to change the technology, and our job was really to evaluate clinical studies that were conducted using the new protocol and the new technology. So here are the review questions that we assessed. The first is, should TB LAMP be used as a replacement test for smear microscopy to diagnose pulmonary TB in all adults with presumptive pulmonary TB? And all of these were tested against a culture reference standard, which I'll describe in a moment. The second part of that question is, should TB LAMP be used as a replacement test for smear microscopy in HIV-positive patients with presumptive pulmonary TB? The second question, should TB LAMP be used as an add-on test for smear-negative patients with presumptive pulmonary TB? And finally, should TB LAMP be used as a replacement test for Xpert to diagnose pulmonary TB? We also evaluated indeterminate results among TB LAMP in these clinical studies, but I won't present the results, only to say that it was very minimal. Our search strategy consisted really of getting a list of ongoing studies from ICANN. It hasn't been rolled out kind of just for regular use, and so independent investigators evaluating it without ICANN's support is minimal because they provide the technology and the training currently. We also conducted a database search through October 2015 using Google Scholar and PubMed. Subsequently, there have been a few additional studies, but that's not reported here. Here are inclusion and exclusion criteria, both at the patient and study level, and you can see we try to be as rigorous as possible in this. The inclusion criteria included that the studies tested sputum samples from all adult presumptive TB patients, that they were conducted in intermediate or high TB burden settings, and that they were conducted after January 1st, 2012, when the technology and protocol of the kits was changed. Exclusion criteria at the study level included enrolling patients who had been on TB treatment within the previous 60 days, or who did not provide speciation testing, or who conducted TB LAMP on frozen specimens. We also excluded patient-level patients from our analysis if they were less than 18, if speciation testing was not performed, or if it went on to become positive for NTM, if they had a documented history of prior TB, if testing was performed on non-sputum samples, and if the TB LAMP reaction volume was less than 25, which was one of the critical changes in the kits following the change in January 2012. This is a description of a hierarchical strategy for our reference standard. There was a lot of heterogeneity in how the clinical sites were conducting culture and reference standard in terms of media and how many samples were evaluated, et cetera. So the reference standard number 1 included TB being defined as greater than 1 positive culture confirmed by MTB by speciation, and not TB being no positive and at least 2 negative cultures performed on 2 different sputum samples. Standard 2 and 3 you can see. I will say that for the majority of the data that we'll show you, we'll be comparing to reference standard number 1. We conducted a Quadus 2 evaluation to assess methodological quality. We don't have time to present the results of all of that here, but you can see that in supplemental material of the guidance as well as in this presentation. We also, in terms of our analytic plan, assessed heterogeneity visually using forest plots and statistically using chi-squared and I-squared testing. And pooled estimates were generated when there were greater than 4 studies available for analysis using hierarchical summary receiver operating characteristic analysis for pooled sensitivity and specificity, and random effects meta-analysis for pooled proportions and sensitivity specificity differences. So here are some of our results. There were 20 studies that were identified. 7 were excluded right off the bat, and some reasons included not excluding patients who had previous treatment within 60 days of enrollment, and 1 study didn't perform speciation. Of the 13 studies that were included, 4 were considered evaluation studies, 1 was a demonstration study, 7 were at the request of ICANN, and 1 was a non-associated study that was done in Haiti and at the time of this work was unpublished. Our study characteristics and demographics and laboratory characteristics are shown here. I think some of the highlights here are that demographics were very similar for all patients at study sites. However, only 3 studies had significant number of patients that were HIV positive, which might be a limitation of this analysis. In terms of the study sites, the most studies performed at least 2 direct Z Nelson smears. The majority had less than 5% contamination, suggesting possible over-decontamination. And all studies performed culture on sputum that was stored for at least 1 day. Some studies did perform Xpert on frozen sediment, and 2 didn't perform Xpert at all. So for our review question number 1, in terms of whether TB LAMP should be used as a replacement test for smear microscopy in all patients with presumptive pulmonary TB. This forest plot demonstrates the sensitivity and specificity TB LAMP in this context with the 7 studies that were available for evaluation based on exclusion and inclusion criteria. You can see that there was a variety of sensitivity reported, 66 to 91%, with visual heterogeneity and heterogeneity by statistical testing as well. In this analysis, smear microscopy had a pooled sensitivity of about 64% and TB LAMP of 77%. And one possible reason for these numbers include, the studies were excluding NTM, which might not occur in programmatic setting right off the bat, the use of suboptimal reference standards, and the potential inclusion of patients who might have been diagnosed with pulmonary TB or on treatment prior to the 60-day cutoff for our exclusion criteria. To review question 1B, which is about HIV-positive patients. The forest plots here again show wide variability in sensitivity and some variability in specificity. And I'll describe the reason for that in a second. Sensitivity varied between 54 and 82%. And there was high heterogeneity in both sensitivity and specificity. And you can, in the interest of time, I'll just kind of show you the pooled estimates up here. Review question number 2 evaluated whether TB LAMP should be used as an add-on test to diagnose pulmonary TB in those who are smear negative. And here you see sensitivity varied widely from 19% to 79%, with specificity ranging between 90 and 100%. And I indicate here Xpert sensitivity pooled estimates and specificity as a point of comparison in this population, the smear-negative population. And finally, for review question number 3, should TB LAMP be used as a replacement test for Xpert in presumptive pulmonary TB patients? And here we evaluated sensitivity and specificity differences. The results that are favoring to the left of the screen, you see, indicate favoring Xpert. To the right favors LAMP. And you can see here that, the results, again, vary widely in terms of sensitivity. It varied from 14% difference favoring Xpert to 3% difference favoring LAMP. And here you see the same results for specificity difference in this population. Again, mostly favoring LAMP slightly, but not by much. It is also interesting to note that the less rigorous the reference standard, the more the studies favored Xpert. And of course, there are limitations with this work. The reference standard, based on our Quadis review, was inadequate in all studies. There was a small number of studies only that were peripheral microscopy centers where TB LAMP might actually be used as a point-of-care test. And there was extensive training as part of these studies and retraining of clinical staff on how to operate TB LAMP, which might not necessarily reflect programmatic conditions if scale-up were to occur. So in conclusion, TB LAMP may be a useful replacement test for smear microscopy or as an add-on following smear negatives in some settings. It's a bit more sensitive than microscopy, and specificity is very similar to that of Xpert. There wasn't an incremental yield of TB LAMP over microscopy observed in our HIV-positive patients, but again, only 3 studies had significant numbers of HIV-positive patients to evaluate. And finally, programmatic conditions should really be evaluated when deciding whether or not to implement LAMP, including infrastructure availability. Our results did suggest that TB LAMP should not be used as a replacement for Xpert. Sensitivity is at the best the same and likely a little bit lower, and there was no information provided on drug resistance. I'd like to acknowledge the team. It was really a team effort at UCSF who put this together, Kate Farr, our statistician, Luke Sternad, and Aditya Kadamanchi, as well as colleagues at the London School, GTB, and FIND. Thank you very much.
Thank you very much for the comprehensive overview of the LAMP test. Sorry, we have no time for questions. We're over time already. So please hold them questions. And after this session, you always have, I think, the occasion, the possibility to meet with each other. I'd like to ask the next speaker, and that is Dr. Kamal from the National Tuberculosis Reference Laboratory in Dhaka, and he's going to present misclassification of tuberculosis as other lung diseases in a tertiary chest disease hospital of a high preference country. Thank you.
Thank you. Respected chairpersons and dear audience, welcome to my presentation. My topic is misclassification of tuberculosis as other lung diseases in a tertiary chest disease hospital of a country with high TB prevalence. The setting was National Tuberculosis Reference Laboratory NTRL at the National Institute of Disease of the Chest and Hospital, Bangladesh. The background study. Bangladesh is a densely populated country with high prevalence of tuberculosis. NTRL is the central TB laboratory of National TB Control Program, Bangladesh. It is responsible for the diagnosis of drug-sensitive and drug-resistant tuberculosis. NIDC is the only tertiary chest disease hospital providing treatment to tuberculosis and other lung diseases. Many unidentified TB cases rolling in the community research tertiary healthcare centers like NIDCs. These cases are often misclassified due to symptoms overlapping with other lung diseases. Now I am trying to show how the pulmonary TB cases remain unidentified and rolling in the community. There is 4 categories of TB cases. These are clinical diagnostic cases. These are bacteriological confirmed cases. These are microscopic level. These are GeneXpert LJ culture level. The bacillary load when is more than 100, and this when is more than 10. That can be detected by the visits. In our algorithms, dot covers all the geographical area, but currently it can detect only 70% of the cases, and 30% remains out of dots due to many reasons and moving in the community. And these cases are not addressed by the present algorithm, and this is also less access. And they are very infectious, and these cases, when moving in the community, either infect the treated cases or it ultimately, in many ways, reaches the tertiary healthcare centers like NIDCs, mainly NIDCs. And if there is a prevention here with the strengthening of the microscopy, here with the Xpert and X-ray here, then this patient can be diagnosed very early before coming to the NIDCs. The objective was to detect drug-sensitive and drug-resistant TB cases from previously diagnosed, provisionally diagnosed non-TB lung diseases, cases admitted in the non-TB ward with or without previous TB history. Early morning sputum was collected from 476 consecutively admitted patients in non-TB wards during April to September 2015. All of them had a provisional diagnosis of lung diseases other than TB on the basis of clinical features, chest X-ray and or spirometry. Sphere microscopy, culture and Xpert MTB reef testing were done in parallel following standard procedures. Now the results. Total 476 cases were screened, and out of them 61 are positive, that is 13%, and 4 were reef resistance and MDR-TB. 114 had previous TB history, and 22.8%, that 26 cases were MTB positive. And 362 had no previous TB history, and 35 of them were, that is 10% was MTB positive. Now the detection of drug-sensitive drug-resistant TB by different test methods. Total 61 was positive, 59 was positive by GeneXpert, 58 by culture, and 36 by microscopy. This indicates the flexibility of the microscopy is still in our setting. 3 Xpert positive cases are negative by culture, but 2 Xpert negative cases are positive by culture. All SMAT positive cases are positive by culture and Xpert. Now the TB cases detection according to disease type and treatment history. These are all provisional diagnosed cases, not finally evaluated. This COPD cases was 172, out of which 27 were positive for MTB, that is 15.6%. Asthma with some exacerbation admitted in the non-TB ward, 90, 4 were positive, that is 4.5%. Bronchiectasis 69, 20% were positive for TB. Space occupying lesion, mainly the destroyed lung, where many of the cases are positive for smell tuberculosis. And there are 56 and 4 were positive for MTB. And in case of consolidation, 46 were tested and 6 were positive. In case of ILD, 26 were screened and 2 were positive. And lung abscess, out of 18, 4 were positive, that's 22%. There's a majority cases detected from these three groups, from these 2 groups. Now the conclusion. A good proportion of drug sensitive and drug resistant TB provisionally remain undiagnosed due to suspicion of other lung diseases. Most of the cases can be detected by Xpert MTB, which is a very simple and rapid technique. This approach may detect all types of bacteriologically proven cases and prevent a spread of infection and ensure early treatment. A scaling up of Xpert MTB at different points of the program is needed, to control tuberculosis. Thanks to Union Secretariat and USAID for sponsoring my tour.
Thank you very much. Again, this presentation shows how important it is to be aware of TB all the time, and then also for the collaboration between the clinical and the laboratory staff. Thank you. Again, in interest of time, I like to continue with the next presentation, and then I also like to ask all the presenters to stay behind our session for people to give the opportunity to ask other questions, to ask the questions you would have liked to ask now. The next presenter is Dr. Moore, and she is from the impressive field research program from MSF, and giving the talk Missed Opportunities again, but now for rapid diagnosis of rifampicin-resistant tuberculosis in the setting of universal Xpert, MTB-RIF coverage in South Africa. Please.
So thank you for the introduction. As mentioned, my name is Erica Moore, and I'm here today to present on behalf of my partners at MSF and other partnering organizations. So first today, I'd like to start out by giving you a little bit of background about GeneXpert MTB-RIF, or Xpert. It's a rapid diagnostic tool used to detect rifampicin-resistant tuberculosis, or RIF-resistant TB. It's recommended for the diagnosis of all presumptive TB cases as to improve the diagnosis of TB and RIF-resistant TB. However, Xpert is the means of diagnosis of RIF-resistant TB less frequently than we would expect, given a sensitivity of 86%. According to a recent linkage to care study conducted in South Africa, we identified that 60% of patients were diagnosed using an Xpert. So this brings about the question whether there's actual missed opportunities for the earlier diagnosis of RIF-resistant TB in our setting. This is data from South Africa, and here you can see the patients that are diagnosed with RIF-resistant TB and the patients that are started on treatment. Here you can see that Xpert was rolled out in late 2011, and post-rollout, you can see that the proportion of cases diagnosed has increased significantly. However, there still remains a gap between the patients diagnosed and those that are actually initiated on second-line TB treatment. And if we're missing cases, this gap could be even larger. This is a schematic representation of the RIF-resistant TB treatment cascade, and these are estimated figures from South Africa. Here you can see that 54% of the estimated community burden is actually diagnosed with RIF-resistant TB. The gap that this analysis aims to address is the gap between the population diagnosed with TB and diagnosed with an actual RIF diagnosis. And this should be a relatively easy gap to address as patients are already in the healthcare system, so screening them appropriately shouldn't be too difficult. And if we can aim to address these gaps, we'll be eventually working towards eliminating the ongoing community transmission of RIF-resistant TB in our setting. So this study took place in Khayelitsha, South Africa. This is a relatively well-functioning DRTB treatment program where we've been providing decentralized treatment at the primary healthcare level since 2008. It is a very high burden RIF-resistant TB setting where we diagnose about 200 cases on a yearly basis. And we have a very high HIV co-infection rate. So about 70% of our patients are co-infected with HIV. This is the diagnostic algorithm being used in our setting. And there's 3 important things that I want you to note about this diagram. First, upon initial presentation, all presumptive cases are required to provide 2 sputum samples, of which the first should be tested using a GeneXpert. Number 2, the results of the first Xpert will guide the clinician what to do regarding the second sample, or guide the laboratory how to process the second sample. And thirdly, if the GeneXpert result is negative, the patient's HIV status should then be taken into account for follow-up action. So as you can see, this is a relatively complex diagram by which there's multiple pathways a patient can actually receive a RIF-resistant TB diagnosis. So the aim of this study was to assess whether the diagnostic algorithm was implemented as per policy among patients that were already diagnosed with RIF-resistant TB in Khayelitsha from January 2012 through December 2014. And specifically, we wanted to assess the proportion of patients where the algorithm was not followed, the breakdowns in the implementation of the algorithm, and what caused those specific breakdowns. We included all patients that were newly diagnosed during the study period using any laboratory method, and we excluded patients with a history of second-line TB treatment, as these patients are likely to be started on presumptive treatment, and therefore the algorithm would not be implemented as per policy for these patients. And additionally, we excluded patients with extrapulmonary TB, as the use of Xpert for patients with EPTB was unclear during the study period. So this was a retrospective analysis where we linked data from patients diagnosed with RIF-resistant TB to data from the first-line TB treatment program to determine if patients were initiated on TB treatment prior to their RIF-resistant diagnosis. We additionally conducted a manual search of each patient on the National Health Laboratory Service database to determine whether there was prior presentation for TB investigation. And we additionally looked at lab forms to then determine potential reasons for algorithm implementation breakdowns. So in the study period, there were 543 patients that were diagnosed, of which 71% were diagnosed using an Xpert. So this is less than we would expect to see. 79% of the cohort had no prior presentation, while 21% had prior presentation. And of those with no prior presentation, 10% were screened incorrectly and never had an Xpert done. Among those with prior presentation, we had to exclude 9 patients as they presented before the availability of Xpert, leaving 103 patients, of which 51% were screened incorrectly at either initial presentation, diagnostic presentation, or both initial and diagnostic presentation. So overall, 18% of the cohort was screened incorrectly at some point in time. So we further looked into the instances where the algorithm was not implemented, and we found that there were 104 total implementation breakdowns. And we found that in some cases, in the majority of cases, no Xpert was done. In other cases, there was a negative Xpert, the patient was HIV infected, and there was no follow-up culture done as per the algorithm. And finally, we found in other cases, no specimen was ever tested. So we further looked into the cause of breakdowns among patients with no Xpert done. In some cases, we found that 2 specimens were sent to different laboratories, and the district lab was prioritizing smear over Xpert. In other cases, we found that only 1 specimen was sent, and there seems to be unclear guidance as to which test to prioritize if 1 sample is received by the lab. And finally, in other cases, we found that no specimens were ever tested. So either patients were started on empiric TB treatment, or the sample potentially leaked and no further specimens were sent for testing. We also looked at the lab requisition forms to further ascertain reasons for implementation breakdowns, and we found that the lab forms do not match the algorithm. So important to note, there's actually no specific place to request an Xpert test on the form. And also, there's no place to specifically record the patient's HIV status. You'll find that oftentimes clinicians are doing this in the remarks section. Oftentimes, we also found that the correct indication for the test was not indicated on the form. So here you'll see that it's indicated case, and months on treatment would be 5 to 7. So this would indicate that this patient was being treated for drug-sensitive TB. However, when we conducted the linkage with the DSTB register, we found that this patient actually wasn't on treatment for drug-sensitive TB. In other cases, we found that there was conflicting information on the form. So in this example, in row 1, you can see that case and MDR is indicated, indicating that this patient might be on treatment for MDR. However, you should only be ticking one option in this section of the form. And additionally, you can see that case and 0 months on treatment is indicated. This is conflicting, but also the fact that case is indicated would lead the lab to not do an Xpert for this patient. So in conclusion, we found that overall 18% of the cohort was screened incorrectly at some point in time, suggesting that diagnoses are being missed. And as this was a retrospective analysis of patients already diagnosed with RIF-resistant TB, this is likely an underestimation of the actual number of missed opportunities for earlier diagnosis. It seems that it's unclear as to who's responsible for implementing testing as per the algorithm. Is it the lab or the clinician? And I think this is one thing that needs some focus in South Africa. Finally, some recommendations coming from this analysis are that the lab requisition form should match the algorithm should be simplified, and lessons learned from Xpert rollout should be considered in the implementation of other diagnostics so that we ensure that we're utilizing these new diagnostics to their full potential, and additionally so that we're addressing the ongoing community transmission of RIF-resistant TB. So I'd like to acknowledge my various different partners and specifically the patients with RIF-resistant TB in Khayelitsha, South Africa. And I'd like to ask you to join us in this campaign to step up against TB. Thank you very much.
Thank you very much. And again, after the session is over, we will continue with the questions. So this was quite a sobering experience, showing that a good diagnostic test is not the only answer. And the next presentation from Dr. Jack Lehev, yes, will again address a sobering question, and that is the costs of the test. So her presentation, she's working for Epicentre, research department in Paris, France, and her presentation is introducing the Xpert MTB RIF test into the diagnostic algorithm of smear-negative tuberculosis, cost-effective. Please, thank you.
Thank you very much. I'm Elena Huerga. I'm presenting on behalf of my colleague Nadia Jakelev, who couldn't come here. So I'm going to talk about cost effectiveness of introducing GeneXpert into a diagnostic algorithm for smear-negative tuberculosis. So we all know that diagnosing smear-negative tuberculosis remains a challenge in resource-limited countries, and Xpert has shown good performance and has been recommended as initial test in high HIV burden countries. However, the cost of using this test, that is 10 USD for the test, may be a barrier for the rollout of the test in limited resource countries. So we assess the cost effectiveness on introducing Xpert assay into a diagnostic algorithm of smear-negative patients with symptoms of pulmonary TB in Kenya. Kenya is a high-burden TB country. Gross national income per capita is 935 euros. And we conducted this study in Homa Bay County. It's a rural area of 350,000 inhabitants. The study was conducted at the chest clinic of the county hospital that provides TB diagnosis of and treatment free of charge, and that is supported by the Ministry of Health and Médecins Sans Frontières. This was a cost-effectiveness study using data from 2 prospective diagnostic studies. The population were adult patients with symptoms of pulmonary tuberculosis and smear negative microscopy results. So we compare 4 algorithms. The first 2 of them were using data from a study conducted from 2009 to 2011, and the other 2 from the subsequent study conducted from 2012 to 2014. First algorithm was based on clinical signs and chest X-ray alone. That was the basic algorithm. Then next algorithm was same clinical signs and X-ray and additional Xpert. Third one was clinical signs and X-ray and additional culture. And the last one was both additional Xpert and culture. Costs were calculated using a microcosting method, and the value of the resources estimated from relevant quantities and corresponding unit price, and a discount rate of 4% was applied since the study duration was more than 1 year. Effectiveness outcome were a number of culture-confirmed TB patients started on treatment. And the cost and effectiveness of each algorithm were compared with the clinical and radiological algorithm, and incremental cost-effectiveness ratios were estimated. So here are the first results. On the cost, you can see in the table the 4 algorithms in columns, and the total cost is at the bottom of the table. Logically, the clinical and radiological algorithm has the lower cost. When you add Xpert, the cost increased to 24,000. Then if you use culture instead of Xpert, it's 35,000. And if you use both, it's 43,000 euros. And then you have below the cost per patient screen, so patient that presented with TB symptoms, and this cost follows the same trend, is lower as expected when only clinical exam and X-rays used, and increase as other tests are used, included in the algorithm. And here in this table you have the cost effectiveness and the incremental cost effectiveness. So first column is the cost, as we have seen in the previous slide. Next column is effectiveness. So this again is the number of culture-confirmed TB cases that were started on treatment. So you can see that the clinical and radiological algorithm allowed treatment on 20 TB-confirmed cases. When Xpert was included, additional 12 cases were started on treatment, up to a total of 32 cases. When culture was used instead of Xpert, 36 cases were started on treatment, and when both were used, a total of 37 patients were started on appropriate treatment. And then the next column is the cost-effectiveness ratio. So we can see there that the cost-effectiveness of an algorithm including Xpert is relatively similar to an algorithm only using clinical exam and X-ray. This is because even if the cost of a clinical exam and X-ray is lower, since there are more cases diagnosed, the ratio remains similar. When culture is used instead of Xpert, this ratio is a bit higher, and when both are used, this ratio is still higher. And finally, the last column shows the incremental cost-effectiveness ratio. So this is comparing all the 3 algorithms with the basic one, clinical exam and X-ray. So when Xpert is added to the algorithm, there is an incremental cost-effectiveness ratio of 825 euros. When culture is used instead of Xpert, this is 1,300 euros, and when both are used, is 1,700. So in conclusion, cost per confirmed TB patient started on treatment using an algorithm with Xpert, and the incremental cost-effectiveness ratio were less than 2-fold the gross national income per capita in Kenya. And if we use this threshold to determine if the algorithm was cost-effective, we find that the algorithm including Xpert is highly cost-effective to diagnose smear-negative tuberculosis. And this leads to think that implementing this algorithm could be affordable in Kenya and in similar context. However, additional culture in the algorithm represented a 2-fold cost per additional patient diagnosed and seems not relevant to introduce. Thank you very much.
Thank you very much. We rush to the final session because new persons are already waiting. The final session from Dr. Tevera Agizu, Senior Researcher at CDC Botswana, Lecture Chair at Faculty of Medicine, University of Botswana, addressing the final question, do our diagnostics really improve clinical outcome of our patients? In his presentation, systematic review, and you can read the rest. Please.
Thank you so much. I don't know if it's good to be a last presenter, but anyway, I will try my best. And I would like to thank you, the union, for inviting us. It's always a pleasure to be here, and of course, my office, CDC, affording to bring me here. So I'll briefly talk about the systematic review and the meta-analysis of clinical outcome of drug-sensitive TB diagnosed by Xpert and smear microscopy. So this is the outline of my presentation. As a background now, as you know, Xpert was endorsed by WHO in 2010, and since then, over 116 countries have implemented Xpert. And by then, one of the expectations was Xpert could double actually the number of TB-HIV cases diagnosed in a high setting, TB and HIV setting. And the other expectation was to reduce possibly a diagnostic delay in early treatment initiation and treatment outcome. Now the WHO was encouraging to do evaluation studies to see if this thing could bring treatment outcome. So our aim, much research have been already done around this, and our aim is to establish the effect of Xpert MTB on patient clinical outcome compared to smear microscopy and determining factors affecting the outcome. Now, in addition to the demographic characteristics, these are potentially other factors that could affect the outcome, like time to diagnosis, time to treatment, incremental value, empiric treatment, loss to follow-up, and so on. So methodology, as any meta-analysis and literature review, we did our selection of articles through 2015 December, and the literature such was conducted in Medline and Mbezi and Union Abstract and other references. And the search criteria was with Xpert NTV outcome and impact and time to diagnosis and so on. So the inclusion criteria for our meta-analysis was treatment articles reporting treatment outcome per the WHO guideline, and the patients diagnosed by Xpert were compared to those of diagnosed by SME. And the outcome, cure and complete was considered as favorable, and the loss to follow-up, days and failure categorized as unfavorable. So this is a result of our systematic review. Through December 2015, 430 articles were published, and of which 53 of them reported on outcome or impact, but only 23 of them reported a patient-level outcome. And we further down go to 4 when we were strict with our inclusion criteria. So only 4 studies reported on treatment outcome, patient-level treatment outcome comparing smear and Xpert. So the majority of the 19 studies actually were excluded from the analysis because the reporting was restricted to one outcome, mostly on mortality. Okay, so these are the 4 studies I was talking about that fulfill the inclusion criteria, and 2 from South Africa, 1 from Brazil, and 1 from Botswana. These are all cluster randomized trial, and the population were a mixture of HIV positive and negative except the Botswana study. So in all 4 studies, the Xpert did not bring any or did not reduce any unfavorable outcome, so there was no benefit from that respect. And when we see the pooled analysis displayed with the first forest plot here, so again, the overall impact of Xpert was not seen here. Only the relative risk was 1.02. It was close to significant, but it was not significant. So Xpert could only improve the treatment outcome by 2%, so it was not significant. So when we see the factors associated with treatment outcome, we managed to see the demographic factors. Unfortunately, all these studies did not break down their factors by Xpert and smear group, but their overall demographic characteristic, when we see that age, gender, and previous TB treatment, all of them were not associated with any better or worse outcome. Only HIV patients were 68% having worse outcome, which is not surprising, of course. So other factors, as I said, affecting the treatment outcome were loss to follow-up, time to diagnose, and so on. So in all these 4 studies, the total TB patient diagnosed were not significant in both arms, I mean smear and Xpert. Loss to follow-up was separately reported only in 2 studies, and there was no difference between the 2. And time to diagnosis was reported only by 1 author, and it was shorter at the Xpert group. And time to treatment reported again by 1, it was shorter among Xpert group. So discussion, this is the first meta-analysis to our knowledge, seeing the effect of Xpert on patient-level outcome in comparison to smear. And overall, as we have seen, Xpert has no benefit on reducing unfavorable outcome or favoring the favorable outcome. Now, Tron et al. Hypothesized in one of the publications that the potential benefit of Xpert was highly masked by a level of rapid empiric treatment. And all this assumption actually was not ruled out by all 4 studies included in the meta-analysis. They still think empiric treatment could have hampered the benefit. So this analysis have also some limitation. First of all, this meta-analysis was limited to only 4 studies, and risk factors such as HIV, CD4 count, and time to treatment, all of these were not in detail included in the publications, and mostly in Brazilian study. And most publications, when they reported, as I said, reported only 1 or 2 outcomes. So 9 out of 19, for example, reported only on mortality, and all of them showed no benefit. And there was also an inconsistent way of measuring in these publications. For example, when they report the outcome, they were reporting presumptive TB versus TB patients. So sometimes the denominator is presumptive TB, sometimes it's TB patients. Time to diagnose was again measured sometime from enrollment, sometime from sample collection. But as you know, time from enrollment obscures patient factor like delayed caused by patient versus health system. This potentially lead to misinterpretation. So in conclusion, our meta-analysis showed no difference in clinical outcome for patient diagnosed by Xpert compared to smear microscopy. And further investigation is needed, especially that includes a problem associated with health systems and only patient factor. And I will leave you with unanswered questions. The unanswered question still we have to see expected outcome. How short should the time to diagnose be, and how short also time to treatment be to see the impact? And to what level should the loss to follow-up be reduced? And finally, to what extent should we limit empiric treatment or control empiric treatment in our diagnosis and treatment of TB? I guess that's the last one. Thank you.
Dr. Akesha, thank you very much, and thank you all for participating in this session. And I also like to extend my thanks to all the speakers for the interesting and remarkable, stimulating presentations.